Welcome, everybody. This is September 10th, 2020, our 10th Ask the Expert, and we have very special guests with us today, including Dr. Shlomi Codish, the Director General of Soroka Medical Center, live from the Negev. We have a very special program today. Thank you for registering in advance, asking your questions. I have here over a dozen questions that you asked in advance, and you're also welcome to type your questions right here in the Q&A icon, and the panelists will see it and can address your question. So I now would like to welcome Executive Director of American Friends of Soroka Medical Center, Rachel Heisler, to offer a greeting to you all. Rachel.
Thank you very much, Pazit, and welcome to all of you. I am delighted for today's opportunity to bring you behind the scenes at Soroka and explore the unique challenges, dilemmas, human impact, and opportunities as we confront the coronavirus pandemic. Soroka is the major medical center for the entire south of Israel and is responsible for the health of 1.2 million individuals. While caring for an intensely diverse population, Soroka is known for excellence, highest quality outcomes, and caring for and uplifting the health of the entire population of the Negev with a unique human touch. And no one is more qualified than Shlomi Codish, the Director General of Soroka, to lead Israel's most strategic medical center, particularly today, to lead the pandemic response. His experience as a physician and pioneering leadership in cutting-edge medical information technology position him so well, and as a result, during the COVID-19 pandemic, Soroka emerged as a true global leader and role model. Soroka's deep immersion in the pandemic response, combined with a rigorous clinical research infrastructure, had led to important studies, which we will hear more about today. I invite each of you to attend American Friends of Soroka's October 18th virtual gala, the Desert in Bloom Gala, to celebrate and support clinical research at Soroka. American Friends of Soroka is a community of leaders coming together from diverse backgrounds to support one of Israel's most important and vital institutions. Visit soroka.org and read the latest news. You can watch videos of past Ask the Expert sessions and also sign up to receive notifications about future events, and also learn more about Soroka's activities during the pandemic and ways in which you can help us support, our life-saving mission. And now I have the honor of introducing Dr. Jay Selman, the president of American Friends of Soroka Medical Center. He is a pediatric neurologist and professor of clinical pediatric neurology at Columbia University. Dr. Selman also has a private practice at Columbia Doctors Child Neurology in New York City, and previously served as the chief of neurology at Blythedale Children's Hospital. His professional expertise and remarkable leadership skills are an inspiration. Thank you, Jay, for all you do for Soroka. And now I pass the mic to you, Jay.
Thank you. Pazit and Rachel, thank you for the introduction to what should be a really interesting program. As we approach the Yomim Noaim, the days of all that include both Rosh Hashanah and Yom Kippur, we reflect upon this past year, and quite an unusual year it has been. What we have accomplished, what we could have done differently, and what are our goals for next year. The American Friends of Soroka adapted to the COVID-19 pandemic. We did this with a change in programming that we do by doing outreach to members and friends of Soroka, and by changing some of the activities. Today's event is the latest in a series of 8 events which have drawn over 1,500 attendees for different Ask the Expert sessions. Today, we are so fortunate to have Dr. Shlomi Codish, an internal medicine physician who is Director General and CEO of Soroka Medical Center. He is going to update us, as Rachel pointed out. Besides outstanding medical care rendered by dedicated physicians, nurses, therapists, and other staff members, Soroka is a leader in many research areas. Shlomi will be sharing an update on Soroka's role in combating COVID-19, as well as clinical and research activities. We look forward to his discussion and vision for the next year and for the future. He will share how Soroka's many areas of research are being translated in to help people at the bedside from the bench, and how patients are being helped every day. Lastly, on behalf of our professional staff and our dedicated board of directors, I want to wish everyone a Lashona Tova and a happy, healthy, and peaceful new year. Now, let us welcome Shlomi Codish. Shlomi, please introduce the topic.
Okay, thank you, Pazit, Rachel, and Jay, for your kind words. I hope I can live up to the expectations you created. What I would like to do in about 10 to 15 minutes, and I'll be aided by a set of short slides, not very detailed, but just sort of help us get a feeling of what's going on at Soroka during COVID-19. Let's see if I can figure out the best way to do this. Let's see if we can get this to do something that's scheduled over here. There we go. Okay. Pazit, is this working now?
Yes, it is. Looking good.
Excellent. So as Rachel pointed out, Soroka is Israel's most strategic hospital. And I'm not going to describe Soroka at great lengths, but our mission is the only tertiary large hospital in southern Israel, covering 60% of the land of the country, places a very large responsibility on the shoulders of hospital staff to provide care. And just to give you sort of a snapshot of who we are, so we're a large referral hospital with about 4,700 employees, 1,150 beds, a very close and strategic affiliation with Ben Gurion University. And we have a very large campus because our forefathers created a huge area in the middle of the desert for us to grow within. The city caught up with us, but that's for a different time. So as we approach the beginning of the COVID-19 pandemic, we see the entire world change, as have we all. And from a hospital point of view, as is for a large part of the community, we're facing a lot of uncertainty. We know we need to prepare for something big, but we're not sure what this something big is. We don't know much about this virus. The Chinese aren't very forthcoming. Various governments are upplaying or downplaying the importance of the virus. And we don't know much about the epidemiology. So we're preparing for a very big unknown where weekly and monthly changes are very common, changing scenarios and changing information. The entire world is facing a shortage of personal protective equipment, of mechanical ventilators, and so on. You've all shared this as well. And life, as we know it, is changing as the education system shuts down and so on. And we're very concerned about the option, about the possibility that Soroka will look like hospitals in Italy at this period of time, where we're seeing horrible pictures from Europe and also from some areas in the US of what might happen to the healthcare system. It's important to understand that how many people are sick and how many people are ventilated are very important from a human tragedy point of view, but they're also important from the point of view of what the capabilities of a healthcare system are. How capable are we to treat more patients? So we're looking at this picture and we need to prepare. And we're looking at our strengths. So Soroka has a few, at least national strengths on an Israeli level, and probably beyond that. One is we're very good in emergency preparedness. We've had, regretfully, times of hostility with the Gaza Strip and various wars in the country. We've had some natural disasters, and we know how to prepare for disaster. And we're the national leaders in infection control. So we pick to start our preparation leaning on these strengths. Again, bearing in mind that the world is not helping us. There are no international protocols and the best way to prepare for this pandemic. And we're faced with the immediate need to construct corona units, start training staff who is not used to working with mechanically ventilated patients or severely ill patients to deal with it, stockpile personal protective equipment to the best of our capabilities when the whole world is no longer willing to sell any of this. Start a research program because we need to know how this virus is behaving in our area and in our country, and adopt a whole set of new technologies to help us cope with this. And we're also realizing this is costing a lot of money because we're buying mechanical ventilators and so on at 50% above the previous rate. And I think you've all seen this from personal experience, the spiking of masks and gloves and stuff like that in the first quarter of the year. So here's something that we think is fairly unique to the way Soroka reacted, and other hospitals in Israel have learned this from us. We built a command center based on our military experience. We built various desks, a clinical desk, an administrative desk, and so on, where teams met daily and solved problems, an infection control team. We used our emergency preparedness team, and each one of these groups on the right met daily, and we met in the command center also daily to learn what's going on. So there were a lot of people involved in this, and we created personal connections because the formal connections weren't working well. Back in March and April, with the Ministry of Health, with the Army, with Klalit, our parent organizations, City Hall, and so on. And this is still working to this day. We still have daily and weekly meetings, depending on the forum, to check how well we're doing. And Israel did very well in the first wave. And I wish I could have stopped with this slide and say, here, we won. Israel, you can see the chart on the right, the number of daily confirmed cases, looking at March and April. And Israel was doing extremely well. A lot of testing, a lot of closure, a lot of personal distancing, to the extent that in May, we thought we were done. And as a result of thinking that we were done, and this is one more view quickly at the death rates, which were also lower compared to the world. And we really were fairly confident that we did a very good job. And as a result, the Israeli society opened up really fast. And maybe one take-home message is this disease develops over 2 to 3 weeks. Every step you take along the way, you see the repercussions of 2 to 3 weeks down the line. So if you close now, you will still see the severe patients from the past 2 to 3 weeks, and only 2 to 3 weeks after closure will you see any results. And what happened with Israeli society is probably because of the very strong measures taken before, we opened something new every 3 to 7 days without waiting to see what happened from the previous closure. And I don't know if you can see the pointer, hopefully you can. But
yes,
from this very low point, we went so high that we're now having more new cases than the US, which was always, sort of an outlier for the Western world, per million population. So the second wave is hitting us very hard. And we can see this here. And it's hitting us hard also with mortality. These are, confirmed deaths per million people. And from very low, we're going now to fairly high. And you can see that we're reaching numbers that Italy was seeing, or not as high, much. This is a logarithmic chart, so the distances are large, but we're not doing as well as an understatement than we were doing before. And the healthcare system is coping, with all the plans I showed before fairly well, but the country around us is providing, let's call them significant challenges to be nice. So the government is looking at what we need to do, and the Ministry of Health is preparing fairly well. And we're told that we need to prepare 60% of our beds for winter for COVID patients, which is a tremendous number, but it allows us the months until winter, until December, to be better prepared. So we come up with a very detailed program, again, leaning on our emergency preparedness program, 5 levels of preparedness. A, which is the level we're in now, B1 and B2, C1 and C2, where we realize that in C2, we will have no longer any hospital activity except for COVID. And in A, we're trying to continue regular activities. And as was the case in the US, the major shortage is nurses. You can see the various stages, the number of nurses that we'll need to figure out how to replace, and equipment. And I know this was a big issue in New York. We saw tweets by the governor of New York, and we're using this information and what happened in various countries and in New York as our benchmark for preparation for winter. And I'm going in the wrong direction, I think. Okay, this is our campus map. Red are buildings that in winter will all be COVID-19. Green are buildings that will continue to be regular patients. Blue are various outpatient and administrative buildings that will be, we expect, not to operate at all. So as you can see, we're using our time now to prepare to the best of our capabilities. Some numbers. We see a lot of patients. These are low numbers compared to numbers New York hospitals, say, saw during the first wave. But these are much larger numbers than we were used to seeing before. And these are numbers we can handle. We're concerned with these numbers, God forbid, increasing significantly. As a number, you can see the number of patients admitted every day increasing day to day with no relent. And now I will say a few words that I will connect to Corona in a second. We consider research to be a major aspect of our activity. This is just a graph of 10 years of published articles. We went from about 150 a year to 450 a year, tripling the number within 10 years. And when we're looking now at the COVID-19, we want to bring this force that we have available to us of researchers and research know-how and figure out ways to innovate and research related to COVID-19. So here are some of the things we've been doing. We participate in every multinational trial with new medications as long as we believe the medication works. We've been trying some new medications and new ideas coming out of Japan, coming out of Israel, coming out of other areas. We're using novel personal protective equipment with fans and with various other systems to help the staff cope better. We have internationally innovative research with ultrasound for patients in intensive care. We were leaders in the area before, and we're now able to not move patients to CT scans or MRIs and perform ultrasounds at the bedside and get good information. Together with BGU, again, an international patent for various testing protocols that will allow us to test for the novel coronavirus with better yields and efficiency. And we're trying out many various new technologies that the Israeli high-tech industry, including the Israeli military industries, are now looking, how can they innovate and help us with Corona? And we have very interesting partnerships with various companies, many of whom previously were not related to healthcare. And various developments in the electronic medical record. I put this on because it's a personal interest of mine. I'm not going to go through this entire slide. This is just a list of various innovations and various research projects that are already ongoing related to COVID-19 at Soroka. This is our dashboard we developed especially, again, based on military command centers with all the information we need on a daily basis. How many patients, how many PPE equipment do we have, how many free ventilators and so on. Various charts available to everyone. How many staff do we have who are in quarantine? I can go on a long time with this. We developed dashboards for intensive care units. Every hospital in the world, I think, ended up developing one of these because you can't go in and monitor the patients closely. If you look at this panel, this is a low-tech advancement for a novel world. Some of our mechanical ventilators do not show information readily from a computerized point of view. So we just put closed circuit TVs facing the ventilators so we can look at the screen of the ventilators from far away. So this is a low-tech solution. The Israeli Air Force came up with a solution that allowed old monitors to extract information, and we can show the information on the regular dashboard. This is still being piloted, but the Israeli Air Force has, I guess, a lot of know-how about how to connect various devices and equipment for monitoring, and they brought it into the medical field. I've got to say they're fairly excited about future marketing of such developments. Remote monitoring, robots that can move around the ward, a chatbot for patients, oops, moving too fast, that can help patients communicate. The elite Israeli commando unit built a tent for us outside of the ED for the first wave, and we'll need to build a similar tent for the winter to increase capacity in the ED. We had a pool open to where this tent, what areas of the world this tent was deployed in before Soroka. They weren't willing to tell us, of course, but this added a lot to our capacity in the ED. Of all the projects, I'd like to tell the story of this project. Our eye doctors discovered patients were not willing to come into the hospital for eye injections. You know, eye injections can save eyesight in many elderly patients, and patients were afraid to come into the hospital. So they worked with Ichud Hatzalah, which I think you're familiar with, an EMS service in Israel, to fit an ambulance to be able to perform eye injections. And they go around homes of patients, call them, come downstairs, we're in the parking lot, inject their eyes and let the patients go back home without the need for exposure to the hospital or risking the loss of eyesight. Now, there are many other similar projects, but these are projects that what makes me particularly proud is this is not a hospital management initiative. The eye doctors came up and said, we'd like to do this, and we were able to facilitate this, which is, you know, the best way a hospital management can expect to operate, with great workers who come up with great ideas. We also saw the Israeli community step up and help us in many ways, sometimes just supporting staff with meals or various other items, and sometimes with funds to help us buy mechanical ventilators and other equipment. American Friends of Soroka were instrumental here, and it's heartwarming to have a community around us that feels a part of us and was able to support these efforts. So I'm going to leave time for questions and answers. I hope this wasn't too long. I'd like to thank you all for your interest at Soroka and ongoing support. Thank all of the American Friends of Soroka. I saw a bunch of you on the participants panels I peeked at. So thank you that despite all that's going on around the world, you find time to help us with this very significant fight that we're all fighting together, and wishing everyone a great new year. Hopefully one we can meet in person in.
Toda raba.
I'm going to stop sharing.
So toda raba. Thank you very much, Dr. Shlomi Codish. That was informing and inspiring. And as I said, I have here about a dozen questions from our viewers, plus a couple of questions now that came in live. So we're going to start related to your presentation and ask you, in light of the use of COVID-related facilities and manpower, women power, is there any reduction in care to other patients? And also, is there a hesitance among the society to come in for health-related issues that are not COVID-related?
So I think the whole world saw a reduction. I'll answer the second part first. Saw a reduction in the utilization of healthcare. We saw a drop to about 50% of activity in March and April. And we're now at about 70 to 80% of our regular activity. When this is something that's entirely elective, it's not justified, but it's not life-risking. But when you see less heart attack patients or stroke patients coming in, you've got to be worried that this is going to be associated with increased morbidity and mortality down the line. And we've come out with several campaigns to the population to explain how we separate COVID-19 patients from other patients and how important it is when you come with a potentially life-threatening issue to undertake the small risk of presenting to the hospital. The first part is regretfully, yes, we've needed, in order to man staff, to avoid the man-woman issue. In order to staff an intensive care unit, we were forced to reduce some elective surgery so we can allocate nurses to intensive care. And in order to open corona units, COVID units, we needed to close down some of our dermatology beds, geriatric beds, and so on. So far, the closure is fairly limited and conscionable. But when I mentioned ethical issues, in one of my earlier slides, it might become an issue. How ethical is it to shut down services for COVID-19 patients?
So the need right now is related to some ethical issues or more financial resources?
So for our current burden of illness, we're fairly well equipped, and support we received until now is fairly adequate. Should the winter, and our major concern is what will happen in winter, when people come into close encounters with family members and so on, we might see a different epidemiological strain come on, and then our major shortage will be personnel, which we'll just need to shift around. That's what everyone in the world did, recruit everyone in the hospital to treat COVID-19 patients. And there's a significant and severe shortage of life-saving equipment, ventilators, monitors, and so on, that the government and Clalit and us are scrambling to purchase. Two issues. One is the cost, and the second is availability, because we're not the only country in the world scrambling to stockpile these equipments in the face. The whole Northern Hemisphere is concerned with similar thoughts.
Speaking about the whole world being in alert and around coronavirus, is there anything that Israel can learn from other countries, specifically from the United States or even other countries? And what can the US learn from Israel?
So we're learning a lot of science and a lot of information about this virus from Western countries who are performing research with a larger number of patients than we have in Israel or had in the first wave. We're regretfully catching up. And a lot of the science that we do is based on such information. So we started, for instance, we started using hydroxychloroquine based on reports out of other countries, and we stopped using it based on reports from the same countries once more information became available. So we're learning a lot all the time. I think what we can contribute to the world is a lot of innovation that is coming out of Israel related to COVID-19, and I really showed a small number of projects taking place. And I think our emergency preparedness program, and I need to be careful and humble here as we've all learned from this virus, but I think the methodology of preparedness from the government down, and as I sort of gave you a taste of what we're doing here, are models that are very useful, and we've had regretfully more chance than some other Western countries to practice these in recent years.
So you mentioned HCQ, hydrochloroquine. How effective is it in treatment for COVID? There is a question here from a viewer.
Current thought is that it is not effective. Again, this is a new disease. We're learning it as we go along. There was a phase where we were using hydroxychloroquine and azithromycin, HNA, I think it was called in the US media. That proved to be dangerous. It proved to be a life-threatening combination. We moved on to the hydroxychloroquine part of it across the world, not really understanding what the proposed mechanism was. And now there are trials out that it does not work. It's still being used in various areas in the world on a research basis, and we might learn something new moving ahead. Currently, it is not being used.
Okay, go ahead.
No, go ahead.
We're going to stay on the COVID-19 issue before we proceed with clinical research questions. So there is one live question here, and I'm inviting everybody that's on the Zoom webinar to put your question, type your question in the little Q&A icon. So we have a question here. What percentage of ventilators are in use currently?
So we currently at Soroka have about 150 ventilators within the hospital. Half of those are fixed to operating rooms and intensive care units. We currently have 50 unused ventilators that are available for the next wave. So we're fairly well equipped from a ventilator point of view for the immediate needs. We need to remember that the reason we have this number of ventilators is that we need them in winter. In a regular winter, those 50 will be in use without COVID-19 additions. We currently expect, I'm trying to count 7 mechanically ventilated patients today. We can handle 20 more. And until winter, we're okay. Come winter, we need more.
So we just want to share that we have 2 amazing college students that took on themselves, initiated a crowdfunding campaign for another ventilator in anticipation of the winter. Those are Miriam Steinberg and James Heisler. And if you go to www.soroka.org/ventilator, you can support. They also put up a lot of related gifts, health-related masks, hand sanitizers and other, if you donate. So thank you everybody for supporting this great young professional initiative. We're staying with COVID-19. Are there any complications for getting the virus after healing from the virus, i.e. heart disease and other complications?
So yes, there are significant illness issues related with COVID-19. People who are healed from COVID-19. We don't quite know yet who is affected and how severely, what the exact risk factors are compared to others. but it seems clear that patients who contract a light form of the disease have less illness or less ongoing complications than patients who experience a very severe form of the disease. And we're thinking this is related to the cytokine storm that I think people are familiar with after about 1 week of illness. And we're looking at immunological diseases, rheumatological effects, lung diseases, heart diseases, I really don't want to scare people, but this is a very nasty disease for people who suffer the consequences. As a result, we've opened a clinic at Soroka for patients who are healing from COVID-19, and they can be in follow-up by a multidisciplinary team of physicians who are on the lookout for these complications, for which there are various supportive measures that can be taken. Trust me, this is a disease you want to avoid.
Of course, but there also has been a question raised about really how do you balance not normal, but some type of civilized lifestyle with the fear and the avoidance of exposure. So there's an example of what about, you know, the outdoors? Is it much safer? You know, if you go by the rules of under just a few people, you know, how can you really balance a lifestyle close to what you're used to, or just not so isolated with that great threat of exposure?
So I can give my personal view here. And, you know, as everyone knows, this is a very charged issue. But we should all say we're going to bid farewell to our previous lifestyle. We're not going to be traveling abroad for vacation until there's a vaccine or treatment for this disease. And if you maintain, you know, the basic rules of, you know, 6 feet, masks, hand hygiene, working within capsules of, you know, people who work together and or outdoors with the same limitations, we can create a reasonable lifestyle, which we're all doing. The problem begins when you become non-compliant and you go to a wedding with 200 people and you dance. And while it's a great activity and everyone would like to get back to that, when you're on a crowded dance floor, people are going to contract COVID-19. And a small percentage of them will become very ill. So, you know, it's a balancing act society cannot afford, because if the healthcare system shuts down, and really the issue here, as I said before, is healthcare system capacity. So we're going to have to keep following rules for a while, folk.
Okay, thank you. We have 2 questions here coming live. One is from our board member. And she says, despite high rate of infected people, it seems that Israel has lower amount of seriously ill. Do you attribute this to lower mean age of population and or other factors?
So yes, we have a lower mortality rate, but regretfully, as you saw on the slides, it's increasing. You know, we thought we were better. We thought we were going to keep a lower mortality rate. The lower age of the population is certainly a factor in this, and as is increased testing. Israel is one of the countries with the largest rate of testing in the world, and testing is associated with discovering more patients than not testing. We have in our intensive care unit now a 20-year-old woman who gave birth last week, contracted, you know, was found to be positive for COVID-19 and is mechanically ventilated in an ECMO. So while this is one case and not a statistic, you know, a nationwide statistic, no one's regretfully immune. And we've had across the country young people with very limited, you know, background illnesses die from COVID-19. But again, so far we are a bit lower than the rest of the world.
And there's a question here, what type of test do you use? Is it the one that's developed by the university across the street, Ben Gurion University Engineering Department?
No, that one is not yet ready for testing for illness and for real patient care. We're still relying on PCR tests. There are various devices and machines. There's a rapid test that we use that can give a result within an hour, but there's still, you know, virus from the back of the throat with the somewhat unpleasant testing mechanism. The various breast tests, serology, and so on are not ready for clinical use yet. But fingers crossed they will be.
There's a question here about a vaccine. Since so many organizations and so many countries are developing a vaccine in time pressure, let's face it, how safe would it be to just have the vaccine, and are we going to be some type of guinea pigs with the first coming vaccines?
So the issue with vaccines is that a very low rate of complications, say you have a rate of complications, a death mortality of 1 in 100,000. You can't afford to give such a medication for the general population because the numbers will be much too big, of patients who react to that. So vaccines need to be much safer than, other forms of medication because a large volume of people who will be receiving them and the fact that they're healthy people with, little to risk. And the rapid development of vaccines is of some concern because if steps are being skipped in the safety issues, then we need to be more careful. Some governments are better at this than others. So for instance, if you look at drugs being developed in the US and Britain and so on, people are very careful and so on. And if you look at the Russian vaccine, so they rushed out and vaccinated a bunch of people and, it'll either work or not. I saw a brief report today saying that their results are not as great as people might have thought. But again, we don't know yet. We need to be careful with this because you're introducing a potentially dangerous medication or treatment into the normal population. Probably, the first people taking these vaccines will be under a certain higher risk than others. One of the reasons that, these vaccines will be tested probably on younger volunteers first, who can afford, whatever risk might be associated more than the elderly population. I will say that the rapid, the amount of energy the Western world is developing is putting into the development of these vaccines. And I think there's about 8 good candidates out there, including an Israeli candidate, can lead us to be optimistic that something will be available, first half of 2021.
Okay, thank you very much. So we have some more questions coming in. So there's a question here, a bit of a long question. There have been various types of figures reported by different states. Most commonly is the percentage of tests which came back positive. However, other places will put out figures of a rate of transmission, which are more effective for monitoring risk and change in cases. Which are more effective?
I'll quote Benjamin Disraeli. There's 3 types of lies, lies, darn lies, and statistics. It depends on what you want to look at. What we look at is the number of seriously ill patients, because it is the measure for hospitals that will tell us what to expect. So if you look at the rate of patients requiring intensive care or severe illness, the rate is less important because I'm concerned with how many patients will be in the hospital. When will I hit 78 patients, which is my current capacity? And in what rate am I approaching that number? So from a hospital point of view, probably that is the more important number. From a national point of view, if someone could figure out a way to standardize this, the percent of positive tests is extremely important. However, if you go out and test, 1,000 school kids with a very low rate of disease, you'll be skewing the numbers on a national level. You're not skewing anything if you look at mechanically ventilated patients or mortality. So from a smaller point of view, probably the hard outcomes. From a national point of view, attempts are being made to figure out a way to normalize these statistics into something that's comparable.
So I want to zoom in now, and we have the great privilege of having you here. I want to zoom into the Negev community. And so it's such a diverse and a big community of mostly lower socioeconomic status. And I want to ask, what are the unique attributes and effects of COVID-19 on this particular community in terms of cultural habits, response, treatment, maybe education, raising awareness, and prevention?
So I'm going to try to figure out a way to answer this shortly because it's a fascinating question initially.
This is another Ask the Expert session.
So, I think so. And probably with people with more expertise. I'll say this, the first wave in Israel was largely people who came back from abroad. And the Negev, being of a lower socioeconomic status, saw a bit less of that. And we had fewer international travelers in the Negev. The second wave is seeing close-knit communities infecting each other. So we're seeing the ultra-Orthodox Jewish community, religious-based activities, weddings, large families living in close quarters, and so on. And the Bedouin population, also with a very large rate of infection and severe illness. For reasons that are beyond me, the Bedouin population have stigmatized COVID-19 as, as a disease to be ashamed of. And we're seeing large communities who refuse to be tested. A van will come in and offer free tests to everyone, and no one will show up because they don't want to be found as positive. Steps the government is taking, such as measured close downs of communities and neighborhoods, are preventing both ultra-Orthodox and Bedouin communities from participating in various programs. So these are issues that are not unique to the Negev, but because we have these populations largely represented, we're seeing a lot of illness coming out of that, this sort of setting. And the other thing we did not really touch on is the devastating economic effect COVID-19 is having on communities, with unemployment rates and closure and so on. And the worse off a community was to begin with, the harder they're hit as this happens. And we're seeing that happen here as well, with the need for support for communities, relief for families and so on. Not yet really a big issue, but we can see that happening fairly soon. So short answer to.
Yes, so speaking about the Negev, what is your biggest concern right now for the Negev going forward?
I think pretty much the previous answer. If we need to get communities to find ways to protect themselves, isolate effectively, agree to go to hotels. The Israeli government sets up hotels for people who cannot isolate at home. There are hotels for ultra-Orthodox community that will, allow a lifestyle appropriate for that community. There was a hotel open for Bedouin women who cannot, share a hotel with men. But again, a lot of reluctance from communities, and we need to get this under control, because with infection rate, the R naught of 1.2 or 1.4 within these communities, we're not going to get under control. We're not going to get this infection under control.
Right. So this remains a challenge because it's not a push of a button to change people's cultures, values, and beliefs. We're going to go a little bit to clinical research at Soroka, and we're going to ask you what are some of the research breakthroughs that have been translated to real-life clinical care that came out of Soroka Medical Center.
Okay, so if we move on from COVID-19, let me just thank Miriam and James for their effort. Were mentioned earlier. So clinical research, as I pointed out, is a very big deal for us at Soroka. We think that it's very important. It maintains staff, it promotes science, and it helps our community. So there are various areas. So there's, I think everyone's familiar with the importance of research in oncology and bringing innovative medication for patients with advanced disease. So we're fairly advanced in that area. We participate in most international and local trials, allowing for very new treatments, many of which are the only, the last resort for patients to be given. Probably the largest area of research where we bring very quick clinical application is genetics. I mentioned there's a large proportion of Bedouin population with a lot of intermarriage within families and genetic diseases. And our genetic institute is probably the largest, the most active in the world in discovering new genes that affect and cause illness. And the Israeli government pays for tests for families where the gene is discovered within a year. So it goes, here's a family we found who has this devastating illness. The Genetic Institute will do the testing that takes a year or two to identify the gene, and the next year we'll be doing prenatal tests to prevent disease. So this is a huge deal, and preventing a lot of suffering. And interestingly, once you've discovered a gene, so a classic example of this is a gene for blindness that was discovered amongst the Bedouin population and turned out to be associated with myopia amongst Sephardic Jews, and a different mutation in the same gene, and was later associated with the Ashkenazi population with a different neurological disease. And all of these is now used at the bedside. Another interesting topic, and again, I'll just touch on it and leave time for other questions, is environmental health. We're on the border of the desert, specifically us and sandstorms coming in from Africa and so on. The world thinks this will be affecting Europe and other areas of the world within, a few dozen years. And we're doing a lot of groundbreaking research on health effects desertification and sandstorms and so on. And there are various specific areas based on, personal expertise of physicians. So we have a lot of cannabis research, first in the world with trials for autism, for geriatric population, and so on. And cannabis, and that of course translates very rapidly to patients' care. And one of our strong points is digital health. We have a lot of information systems in Israel in general, a lot of startup companies, and a lot of small projects to start out are applied to patient care very rapidly. And again, we could spend a long time discussing this. I think these are the major areas.
That's wonderful. I'm inviting our viewers to check out Soroka.org website. We have had a session about autism in collaboration with Ben-Gurion University. That was very, very interesting, hosting 4 experts about that. So that's wonderful. There's a question here. How are you adjusting and altering studies according to the dynamics of clinical research that is being evolving around the world? Are you in touch, connecting with other research institutions? Are you collaborating other than Ben-Gurion University? How does that work on a global impact level?
There's researchers from Ben-Gurion who participate with, I think, every major US university, with many hospitals across the world. I invite you to look us up on PubMed and look at Soroka researches. Research is a global effort. It's not a local effort. Very few major groundbreaking research can take place at a single institute, and even with a pair, university and a hospital. And once an idea takes off, you need to gather patients and expertise and information and various resources that are not always available in a specific area. And we're very strong collaborators. We enjoy collaboration. We work with other universities within Israel. We've worked with Weizmann, with Tel Aviv, with Hadassah, it's various large universities for various projects. Some we lead, some we follow, some we collaborate. And there's no modern research without such collaborations.
So there is a question from a board member. How can we, American Friends of Soroka Medical Center, support your effort? What is right now a major need in terms of clinical, groundbreaking research, innovation, technology? I'm sure there are many specific needs, but in general, how does our support impact or help you out?
So equipment is always an issue because funding for research in Israel is probably a percentile, a thousandth of what the US invests in research or other Western worlds because of other pressing needs of the country in general. And we have a lot of ideas that sometimes get stuck based on either minor staffing issues or equipment. For instance, we are collecting genetic samples for our biobank, but we're not sequencing them yet. We're collecting the samples and we expect sequencing to take place as funds become available for a specific research project. So there's various equipment needs associated around that. And many ideas need, a certain seed amount of funding for a researcher to develop a pilot, first in man or other projects before the industry can be approached for funding. And philanthropy has been very effective and useful for such issues. We're building a new research building, which again, we can go into length, but I'll just suffice it to say we will have a building together with Ben-Gurion with a large gift from the Adelis Foundation, which we're very grateful for, but many needs for, more building and funds to complete the building, which, even small amounts can make a large difference within that building. So I would say, support individual researchers, equipment, and the building.
Wonderful. We're inviting everyone to our October 18th Sunday brunch in a desert chic mode to support and celebrate clinical research at Soroka Medical Center. Thank you very much. There are a couple more questions also related to COVID and to Soroka Medical Center. So one is if you have other conditions and if your immune system has been lowered because of, let's say, chemotherapy or radiation treatment, are you more susceptible to COVID, and will the vaccine affect you if your immune system is lowered?
So the first part of the question is interesting and touches into what I mentioned about some humility before in facing this virus. Initial research projects said that patients who are on chemotherapy or cancer patients are prone to a much more severe course of disease. And we implemented various measures to prevent COVID-19 from entering the new Legacy Heritage Oncology Center and the Dr. Larry Norton Institute. We require testing, we isolated patients, and so on. Current research says that the course of disease is probably not significantly affected by cancer and more by metabolic diseases. I would advise to be on the conservative side and be careful and try to avoid disease and avoid contracting it and so on. But current evidence seems to be a little more favorable than it was a few months ago. As I said, the next trial might say something else. We're in early steps. As far as the vaccine goes, various vaccines will work and are designed to affect the immune system in different ways. And there are vaccine candidates that can be given to people with immune systems who are down. We don't know if they will reach production or safety levels yet. But it is reasonable to assume that amongst the various forms developed, there will be vaccines that are more fit for certain populations than others.
Is there evidence to show that children with some heart defects are more susceptible to getting COVID-19?
To the best of my knowledge, not. This is not my area of expertise. I don't think there is a significant risk of it contracting the disease. However, anyone who has a significant heart issue might suffer from the disease worse than others with less reserve of the cardiopulmonary system. Therefore, again, it makes a lot of sense. If you go out to play at a park, go out and play alone. Don't play with other kids around, because kids usually get the disease in a much lighter form than adults. But a light form in a healthy kid is different from a light form in an unhealthy kid.
Okay, we discussed so many challenges and complications with the pandemic. I want to turn into a potential opportunity and ask you, well, first of all, mention one opportunity that we've been experiencing is afforded by technology, is coming together with experts as yourself and your dedicated staff, joining our American experts and supporters and viewers, coming together through Zoom and other technology interactions, and just strengthening one another through technology, through informing one another, through feedback and support. So that's not only financial. So we're grateful for that. And I want to ask you, do you see any potential opportunities that are presented by the pandemic, or is it all challenges and complications?
An interesting question. We're making a lot of breakthroughs in medicine facilitated by shortcuts and rapid development and collaborations that previously were difficult to create due to the pandemic. And I think it's a little sad, that we need to have such a pandemic for industry, university, and hospitals to share, forces together. But it's okay, that's human nature. And hopefully we'll be smart enough to keep this up once the pandemic is over and not revert to, silos and competing over intellectual property and competition and so on. So there's a huge opportunity here, but changes in the species behavior, as you said before, will take longer possibly than it will take to conquer a COVID-19. A lot of the way we practice medicine has changed, some to the better, some not. And telemedicine is a great thing until someone needs to talk to someone and connect better than technology will allow. And one of our challenges will be taking the right stuff out of this and not the wrong stuff, and making sure we keep humanity alive despite various financial and other incentives that might emerge coming out of COVID-19. But the potential is definitely there. It's up to us to realize it.
Do you deal with a lot of mental and loneliness and other mental conditions deriving or uppicking, from the pandemic? And how do you approach that? How do you cope with that?
So there is a lot, and there will be much more. and our mental health professionals across the city are planning, working together, opening clinics and so on. A very important topic is the way staff reacts to COVID-19. A lot of burden is being placed on people who are now facing personal hardship at home and at work. Treating patients under protective gear is physically difficult. Dealing with much more deaths than people dealt before is difficult. The roller coaster of emotions, everyone supporting everyone, clapping hands to staff, and versus reverting back to previous methods and so on. And we're creating several mechanisms to support staff and trying to be as cognizant as we can of units that need relief and support. And so for instance, the nurses in our intensive care unit are under tremendous hardship continuously. But they said that what they wanted is for us to support them to go out to spot treatment in the Dead Sea. And while we can afford it, we can't afford to risk them all being infected together in the same spot treatment. So we're trying to figure out a way to provide relief to staff as well. So you asked about the population, but I think we all need to be concerned about medical staff. This is a marathon. This is not a sprint. And this is going to take a while.
For sure. What are you most proud of when you think about the medical staff in such a huge institution such as Soroka Medical Center?
The devotion. Our staff is, and again, I'm not really sure that's the correct translation. Mesirut, probably devotion.
Devotion, dedication.
We started the first wave and we started looking for people to work in our COVID-19 unit. And this is a time where people were terrified and we thought everyone was going to die. We didn't know enough about the disease yet. And we were discussing and manage it. What lottery system would we use? How will we get people to work? How will we convince people? And until now, we've always had more people willing to work in those units than our need. Our staff works in the Negev, is very closely connected to the community, feels a sense of mission in treating these patients. And I'm endlessly proud of having such a staff that work for me or work in the hospital with me is a much better way of defining the relationship we have going on here, with a sense of identity of mission. There's no way I can underestimate how important this is and how empowering it is for the staff first, and also for hospital management to know what kind of following you have and what kind of willingness you have to go to extremes in treating population.
Yes, that's very touching and very inspiring. Thank you for sharing that with us. And perhaps the last question would be, you have a big job, not an easy job. I don't know how many people would want your job. But thinking back to what maybe strengthens you, empowers you, inspires you, what is one advice that you got in life that you turn back to when you need a little bit self-support?
Everything in Pirkei Avot, or 90% of it, are good rules to live by. Ve'afta l'reacha kamocha, love your neighbor as thyself. I don't think you can be in the healthcare profession and not follow that to the best of your abilities. And I like, my website has this, and the title of it, depart from evil and do good. Seek peace and pursue it is always good advice in Israeli society and probably humanity as well. Words to live by, and the Bible is always a good source as well. So it's not a personal advice, but Chachamenu Zichronam Livracha, and that there's no way I'm going to be able to translate that into English. But
Chazal.
A lot of
I don't know Chazal in English. Yeah. Okay. That's thank you very much. I wanna just touch on the emotional coping that here at American Friends of Soroka Medical Center, we are actually developing an Ask the Expert series about coping and resilience. hosted by our board member, psychologist and psychoanalyst, Dr. Teresa Rosenblatt, with special guests. So stay tuned to that. And you can also check out the website, soroka.org, and see other emotional coping sessions that we had before with psychiatrists from Soroka Medical Center and some people from here, experts from here. So toda rabba, thank you very much. And I thank everyone for joining. I thank you, Dr. Shlomi Codish, Dr. Jay Selman, our executive director, Rachel Heisler, toda rabba. And we will see you soon. Shana tova, everybody.
Shana tova, and thank you all for setting this up. It was a great opportunity. Shana tova.
Shana tova.